Okay, so bisphosphonates versus rank ligand inhibition in bone metastases. 30 to 40% of patients with lung cancer will present with bone metastases. And bone metastases have debilitating consequences, which are called skeletal-related events, or SREs. And they represent fracture, radiation to bone, spinal cord compression, hypercalcemia, and surgery to bone. SREs have consequences such as loss of autonomy, significant morbidity, bone pain, reduced quality of life, and increased healthcare costs and resources. But the ultimate consequence is decreased survival. In a phase 3 trial of zoledronic acid versus placebo in solid tumors and non-small cell lung cancer, but not breast and prostate cancer, 46% of patients developed SREs. And mean number of SREs per patient per year in these solid tumors was 2.71. We know that the survival now is increased in metastatic lung cancer, and it doesn't take long to develop SRE. Median time to first SRE in the trial which I mentioned was only 5.2 months. And non-small cell lung cancer patients with SREs in one study had about 50% shorter survival than patients without SREs. So the first bone-targeted agents which we had were bisphosphonates. And here you see nitrogen-containing bisphosphonates, which block farnesyl diphosphate synthase, and thus blocking the prenylation of small signaling proteins required for cell function and survival. Here is the phase 3 trial, zoledronic acid in patients with bone metastases from non-small cell lung cancer and other solid tumors, and as I mentioned, prostate and breast cancer patients were not included in this trial. Patients received 257 zoledronic acid 4 milligrams every 3 weeks over 15 minutes, and daily oral vitamin D and calcium. The arm with 8 milligrams of zoledronic acid was changed to only 4 milligrams for concern of renal safety. And this was compared to placebo every 3 weeks. The final analysis was performed at 21 months. Stratification was based on non-small cell lung cancer versus other solid tumors. Non-small cell lung cancers represented in this study were 49%, or 244 patients, renal cell cancer 9 patients, small cell lung cancer 7% of patients, and you can see all the other cancers which were represented. Zoledronic acid reduced percentage of patients with each SRE, as you can see. With a very significant p-value, less than 0.05. And zoledronic acid also delayed time to SREs in patients with non-small cell lung cancer and other solid tumors. Median time to first SRE, you can see significant p-value of 0.009, delay of 81 days, time to first pathologic fracture with significant p-value of 0.02, and time to first palliative radiation p-value of 0.05. Zoledronic acid reduced the risk of developing an SRE in the whole group, risk reduction 31%, p-value 0.003, and in the non-small cell lung cancer group only, risk reduction of 32%, p-value 0.01. Also, there was a reduction in the risk of SREs in patients with history of SREs prior to entering on the trial. And you can see that the risk reduction was 31% with a p-value of 0.0009. In comparison to no prior SREs, 23% reduction, no significant p-value. There was no significant difference in survival in the overall population, placebo or zoledronic acid. Preventing SREs reduced cost of managing lung cancer patients with bone metastases. You can see the difference in dollars, $27,982 in a trial comparing 162 patients in each arm. We have now biochemical markers of bone formation and resorption. For bone formation is serum bone-specific alkaline phosphatase, or BAP, and for resorption, it's entelopeptide of type 1 collagen, measured in urine or serum, NTX, or C-telopeptide of type 1 collagen, CTX. Elevated NTX levels were associated with an increased risk of negative clinical outcomes such as SREs, p-value 0.01, disease progression, again p-value 0.01, and death, less than 0.001. Zoledronic acid normalized NTX levels within 3 months in most patients with elevated baseline NTX, and that was true in breast cancer, prostate cancer, and non-small cell lung cancer and other solid tumors. In this group by 81%. And normalization of NTX levels with zoledronic acid improved survival. You can see again that the p-value is significant now, 0.01, with a risk reduction of 57%. Survival in patients with non-small cell lung cancer and normal baseline entelopeptides did not show any improvement. Survival in patients with non-small cell lung cancer and high baseline NTX who received zoledronic acid showed improvement in survival with risk ratio 0.65 and p-value was significant, 0.02. And by multivariate analysis, zoledronic acid significantly increased survival in non-small cell lung cancer patients with high baseline NTX with p-value of 0.0047, 43% risk reduction of death compared to some other variables, for example, narcotic use or ECOG performance status, which were also significant but less than impact of zoledronic acid. So rank ligand plays a destructive role in patients with bone metastases from solid tumors. Osteoblasts and other bone cells produce rank ligand, and it stimulates osteoclastic activity, and by that also increases resorption of the bone. There is a vicious cycle which happens if there is an overproduction of rank ligand. It drives increased formation, function, and survival of osteoclasts, leading to excessive bone resorption. And both resorption releases growth factors from the bone matrix that may perpetuate tumor activity. And then tumor cells produce factors that stimulate osteoblasts to secrete rank ligand. So we have a situation of vicious cycle. Rank ligand is essential for osteoclast formation, function, and survival. And Denosumab is fully human monoclonal antibody to rank ligand, IgG2 immunoglobulin isotype, with high affinity and specificity for human-like ligand. It is administered via subcutaneous injection. And you can see that it can break the vicious cycle of bone destruction by binding to rank ligand, inhibiting osteoclast formation, function, and survival. So we have randomized double-blind study of Denosumab versus zoledronic acid in the treatment of bone metastases in patients with advanced cancer, but excluding breast and prostate cancer, including multiple myeloma. Key exclusion was that patients could not have current or prior intravenous bisphosphonates. 886 patients received Denosumab, 120 milligrams subcutaneously, and placebo IV every 4 weeks. And 890 patients received zoledronic acid every 4 weeks, 4 milligrams IV, and placebo subcutaneously. Again, patients received supplemental calcium and vitamin D. Primary endpoint in the study was time to first on-study SRE for non-inferiority, and secondary endpoints were time to first on-study SRE for superiority and time to first and subsequent on-study SREs for superiority. You can see that the baseline characteristics were well-balanced. Non-small cell lung cancer represented 345 and 343 patients, and myeloma patients in the study represented 10% of the patients. Time from first bone metastases to randomization were 2 months. Previous SREs and presence of visceral metastases were in each arm about in 50% of the patients. So time to first on-study SRE reached non-inferiority with p-value of 0.0007, but it did not reach significant superiority. There was a trend with p-value of 0.06, 20.6 months on Denosumab and 16.3 months on zoledronic acid. Time to first and subsequent on-study SREs by multiple event analysis did not reach superiority, p-value 0.14. And time to first and on-study SREs for solid tumors only, when we take the 10% of patients with multiple myeloma out of study, reached superiority. Denosumab 21.4 months median, zoledronic acid 15.4 months with a p-value of 0.01. Time to first and subsequent SREs for solid tumors only, again, p-value of 0.04. And when we look at adverse events of interest, we can see that acute phase reactions, especially the first 3 days, were higher on zoledronic acid, 14.5% to 6.9%. Potential renal toxicity adverse events, they are definitely higher on zoledronic acid, but here are some renal side effects because of chemotherapy. But we have to remember that zoledronic acid needs renal monitoring and adjusting of dose, while Denosumab does not. There were cumulative rates of ONJ, osteonecrosis of jaw, which were about 1% in both arms. Overall disease progression and overall survival were the same in both arms. Now, pain outcomes in a randomized phase 3 trial, which I just discussed. Baseline pain and analgesic use in both arms were well balanced. And you can see that Denosumab delayed time to moderate severe pain in patients with no or mild pain at baseline. And the risk reduction was 19%. It was median of 4.7 months on Denosumab to 3.7 months on zoledronic acid, significant p-value 0.04. and proportion with no mild pain at baseline, reporting moderate to severe pain by visit, also showed advantage to Denosumab, 10% average relative difference per visit. A worsening of pain, again, advantage to Denosumab, 5.6 months median for Denosumab and 4.6 months for Zoledronic acid. So consistently lower proportions of Denosumab-treated patients reported clinical significant pain worsening, 5% lower on average from months 1 to 11. Clinically meaningful pain improvement was not seen, no difference, but when we read in publications about pain improvement, we also need always to know what was actually consumption of analgesics. And when you look who shifted to strong opioid use, you can see that there is average relative difference of 22%, that more patients actually shifted to strong opioid use on zoledronic acid. So we also know that these agents have anti-cancer activity. We know more from this point about zoledronic acid. Zoledronic acid has both direct and indirect anti-cancer activity. The direct activity is suppression of tumor growth, induces tumor cell apoptosis, synergy with anti-cancer drugs, and indirect effects, inhibition of angiogenesis, stimulation of immune system, decreases matrix invasion by tumor cell, and decreases adhesion to bone. So what are actually the effects on overall survival improvement in patients in this trial? And again, you can see that non-small cell lung cancer was represented by 352 and 350 patients, of which adenocarcinoma represented 60% of, or 211 patients on this study, and Denosumab 54% of patients, 189. And there were some patients with squamous cell, 21 and 25%, and then some other lung cancer types, small cell lung cancer, 12 and 15% of patients. So majority were adenocarcinomas. Baseline characteristics were well balanced, just to remind you, and time from diagnosis of bone metastases to randomization, 1.6 and 1.5 months. Most of the patients had prior systemic anti-cancer therapy, and about 49 and 46% of the patients had already prior SREs. And overall survival favored Denosumab, 8.9 months median to 7.7 on zoledronic acid with p-value of 0.01. Patients with small cell lung cancer, Denosumab 7.6 months median, zoledronic acid 5.1, but p-value was not reached, significant p-value. When you look at non-small cell lung cancer, 9.5 to 8.1 months with significant p-value of 0.01 and hazard ratio 0.78. And by histological types, in adenocarcinoma, 9.6 to 8.2 months, p-value 0.07, and in squamous cell cancer, p-value 0.03, and it is 8.6 months compared to 6.4 months on zoledronic acid. So in summary, in this exploratory analysis of a large subgroup of patients with non-small cell lung cancer and small cell lung cancer, and bone metastases, Denosumab treatment is associated with significantly improved overall survival versus zoledronic acid. And preclinical investigations are underway to evaluate if RUNCL inhibition has a direct anti-tumor effect on lung cancer cells. And I just want to summarize yet that results from a phase 3 randomized trial in patients with solid tumors, excluding breast and prostate cancer and multiple myeloma, and bone metastases showed denosumab was superior to zoledronic acid in delaying time to first on-study SRE, delaying time to first and subsequent SREs, and the subgroup analysis demonstrated better pain control and superior survival on denosumab versus zoledronic acid. Thank you for your attention.